Hola. So we will continue and pick up where we left off after my last talk and move on to talk about migraine treatment. This is a very exciting time to be a migraine specialist because we have a lot of new treatments that are coming out that are based on migraine pathophysiology, and I think give my patients quite a bit of hope. So here we go. Those are my disclosures, and in the next 30 minutes we will try to meet the following objectives. We will identify the principles and objectives of preventive therapy. We will discuss how to educate patients regarding medication overuse and medication overuse headache. We will explain how to counsel patients about preventive treatment. We will discuss treatments that are supported by randomized, controlled clinical trials, and list what factors might influence our choice of a migraine preventive. And then we'll also discuss when a migraine preventive medicine should be considered. So it always starts with a patient. This is Mina. She's 24 years old, an otherwise healthy and right-handed woman who has a long-standing history of headaches that started in grade school. She comes from a family that has many individuals who suffer from migraine. She comes in telling you that she's now having about 2 to 3 migraine attacks per week. So at this point, you would step back, think about snooping for red flags and exclude a secondary cause of headache, diagnose her with migraine, try to optimize her acute treatment, and because her headaches are so frequent, you'll talk about, what are the next steps in terms of migraine prevention and what would be the best option for her. Migraine prevention is underutilized. This has been studied in a few different epidemiology studies dating back to 2007. In this study from the American Migraine Prevalence and Prevention Program, we found out that out of all individuals who suffer from migraine, only about 3 to 13% of those patients are on a preventive treatment, while up to 40% of patients are eligible and should be offered some sort of medicine to help reduce their attack frequency. And this is even more significant in patients who have chronic migraine. This is a study, the CAMEO study, published in 2016, that involved over 1,200 patients. And the conclusion here was only 4.5% of individuals with chronic migraine are seen by a physician for their headaches, receive an appropriate diagnosis, and are put on appropriate treatment. So that is a huge unmet need right there. We should consider placing a patient on migraine prevention for a variety of reasons. I think most commonly in my practice, if my patient's having more than, say, 1 attack per week, we'll talk about prevention. Or if I'm concerned that they're using acute medicines more than once or twice a week on a consistent basis and therefore kind of approaching medication overuse, we'll talk about prevention there too. Even if the patient's attacks are less frequent but they're significant, associated with significant disability, that patient might also benefit from a preventive medication, as well as if they have uncommon migraine variants for which there are not good acute treatments, or the acute treatments they've tried have really not been helpful. Those are all good reasons to put someone on a preventive. But I think the most common reasons would be if they have migraine attacks more than once a week or need to use acute medicine more than once or twice a week on a consistent basis. When you talk to your patients about migraine prevention, there's a few different things that I think are worth mentioning. First of all, the goals of migraine prevention are a few different things. We want to try and reduce their migraine attacks, also their headache attacks, so those headaches that don't meet full migraine criteria, we want to dampen those as well. We want to reduce the intensity of their symptoms and reduce migraine-associated disability. And sometimes when patients are on a preventive treatment, their acute medicines may actually work a little bit better. And we talked about this in my previous lecture. If a patient has frequent migraine attacks that are not being treated, that is a risk factor for developing chronic migraine or chronic daily headache, and we can prevent that as well. It's also very important to tell patients that it can take a few months for these changes to occur. Oftentimes they need to be on a stable dose of medicine for about a month or 2 or longer to see improvement. So I think setting up reasonable expectations is very important. Not only do we need to tell patients that they need to be on their adequate dose of medicine for a month or 2, so an adequate treatment trial, if you think about the fact that with our existing migraine preventives, it can take a full month to even get up to that dose, that adequate treatment trial is about 2 to 3 months. Not only is telling them that point important, but there's also a few other, principles of migraine prevention. First of all, with our currently available migraine preventive medicines, we typically start with a low dose and increase it very slowly to reduce the risk of side effects. While we're doing this, we'll monitor patients for their acute medication use and monitor for any medication overuse that might be interfering with their headache as well. And sometimes, these changes can be a bit slow and subtle, so having a patient maintain a headache diary can also be very helpful to monitor for change. Because migraine is most commonly affects young women or women of childbearing potential, and most of the medicines that we have to use for migraine prevention can lead to birth defects. It's really important to talk about contraception. And then, we'll talk about how to choose a medication, but really, the currently available options can have a variety of different side effects, and we can kind of use a few different tricks to pick the best option for any given patient. And that really has to do with the patient's other medical issues. So, for example, if a patient has asthma, you might want to avoid a beta blocker. If they also have depression, maybe amitriptyline would be a good option. So using medications that might be helpful for more than one problem, or avoiding medications because of certain issues is important to think about. We currently have several different medications that are available with different levels of evidence. So divalproic sodium, topiramate, and several beta blockers are considered first line based on the available randomized control studies with these drugs. Amitriptyline, venlafaxine, and a few other medications are second line, mainly just because these medications are a little bit older or they haven't had as much of the high level randomized control studies to support their use, but they can also be very effective in patients. Other medications that could also be considered include things like lisinopril or candesartan, and some patients really do well with other things like verapamil or gabapentin as well. So we have a wide variety of medications that we can use with different levels of evidence from a randomized controlled study standpoint that would support their use too. Specifically in chronic migraine, a handful of drugs have been studied to date. This includes topiramate, gabapentin, valproate, amitriptyline, fluoxetine, and tizanidine, with varying levels of evidence, but can potentially be helpful for those patients. And of course, onabotulinum toxin type A is also approved for chronic migraine. And patients come to me asking about this. They'll tell me that they had Botox for their wrinkles and their headaches have gotten better. Is that truly possible? And I can tell them, yes, it is. And we can talk about that and consider using it. So onabotulinum toxin type A, or Botox, gained approval in the United States in 2010 based on this huge clinical trial called the Preempt program, which involved over 1,300 patients, all of whom had chronic migraine. The patients were randomized into one of two groups, the group that received Botox or the group that received placebo. And there was a double-blind phase, so these subjects had their study drug injected, 12 weeks later, second injection, 12 weeks after that, or at week 24, that was the primary endpoint, and the two groups were studied. And at that point, all subjects entered an open label phase, and they all received Botox as well. And the study was positive at week 24, which is the primary endpoint. There was a significant difference between patients who received Botox and placebo. And what you'll note here is that in the open label phase, when all patients were given Botox, they all did well. However, the patients that started off receiving the onabotulinum toxin type A from the randomized portion, they actually continued to do better than the patients that were initially randomized to placebo, suggesting that there might be some long-term benefit to these treatments as well. And this is the approved protocol and what we use in our practice. So it's a fixed site, fixed dose injection strategy. Patients receive 155 units divided over 31 locations, 5 units per location. Involves the corrugator, the procerus muscles, the frontalis, the temporalis, the occipitalis, the cervical paraspinals, and the trapezius. In the trials, the clinician and the patient were also given the option to inject an additional 40 units depending on the patient's pain, and we often use that as well. We think onabotulinum toxin type A works in migraine actually by blocking, the release of these nociceptive neuropeptides at these trigeminal afferents, so blocking the release of CGRP, for example, and reducing that pain transmission, that central sensitization. It can also inhibit the release of several neuronal signaling markers. And from the central nervous system, studies have shown us that onabotulinum toxin type A will reduce CFOS gene expression at the dorsal horn and the trigeminal nucleus caudalis. So there are multiple ways that this works to reduce migraine frequency based on our understanding of migraine pathophysiology. Not only is it effective, it's also very well tolerated. You'll see here that, only neck pain and muscular weakness were affected by more than 5% of patients who received Botox. And we've actually been able to modify our injection locations a little bit to reduce that risk even further. So patients do really well with this treatment. I mentioned before that this is the age of migraine treatment and a really exciting time to be treating these patients because we have a lot more tools in our toolbox. And they have to do with our understanding of migraine pathophysiology. I think when we look ahead to migraine treatment, what's coming is treatments that target calcitonin gene-related peptide and also these non-invasive neuromodulation devices. Currently, in the United States, we have 3 devices that are cleared for migraine treatment. This single-pulse transcranial magnetic stimulator, this STMS device, has been approved for the acute treatment of migraine with aura based on a randomized clinical trial where patients are asked to use the device at onset of their migraine attack, and it was shown to be superior to placebo in aborting their attack. And a later study, an open label study of patients with both episodic and chronic migraine, migraine with aura, migraine without aura, were asked to use the device twice a day and were followed for 3 months. And we're shown to see a reduction in migraine frequency as well. So now it's approved for both acute treatment of migraine with aura and also for migraine prevention. So this is a great option for patients who don't want to be on a medication. The downside to it is the cost. It's quite expensive and not completely covered by insurance in the United States, so sometimes patients have a hard time getting it. Another device that we have available is this transcutaneous supraorbital stimulator that's attached to the forehead. It stimulates these supraorbital nerves. There was a small study published in 2013 with 67 patients, randomized, all of whom had episodic migraine. They're randomized to either placebo or sham device or the true device, and advised to use it every day for 20 minutes and followed for 3 months. At the end of the 3-month period, the patients who were given the true device saw a reduction in their headache frequency, which led to this device gaining approval for migraine prevention. And just last year, there was another study, a small open label study in patients who had migraine. They were asked to use this acutely. So when they had a migraine attack, they were advised to use it for 1 hour, and it was shown to be beneficial. So now it's cleared for both migraine prevention and also migraine acute treatment. And most recently, there's this non-invasive vagus nerve stimulator. So it's this handheld device that you just put up to the vagus nerve at the neck, turn it on. There was a study published actually just a few months ago, which was a randomized sham-controlled study with 248 patients, all of whom had episodic migraine, and they were told to use their device with their migraine attacks, and the study found that the true device was superior to placebo in aborting migraine attacks. It's another, non-medication treatment option for migraine that we have. I mentioned that a lot of our advancements have been with migraine prevention, but there's a few noteworthy things about acute treatment that I'm going to point out as well. Currently, for acute treatment for migraine, our available medications are triptans, which are serotonin 1B and 1D receptor agonists. They work really well. The main problem, though, is that they bind to blood vessels and can lead to constriction. So if a patient has heart disease, stroke, heart attack, they're not allowed to take that medication, and there's very little left that we can offer them. And so there's been a few new treatments that have been developed. Lasmiditan is a serotonin 1F receptor agonist, so does not involve the blood vessels at all, and has been shown to be superior to placebo and effective in aborting migraine attacks. So for patients who have vascular risk factors, this may be an option for them to use for acute treatment of migraine. We also have a couple of CGRP receptor antagonists that are being studied for acute treatment of migraine. So we talked before about how calcitonin gene-related peptide is involved with the migraine pathophysiology, and blocking that, for example, with sumatriptan, can abort a migraine attack. And so blocking it with a receptor antagonist can also do the same thing, and this also doesn't have the same vascular risks. So we're hopeful that these CGRP receptor antagonists can be used for patients who are ineligible to take other medications. So, and finally, migraine preventive treatments. This has been gaining a lot of attention because we've just recently have approved erenumab, which is also known as brand name Aimovig, which is a CGRP monoclonal antibody. We were involved with many of the studies with this drug, and it's been gaining a lot of attention and excitement because of how helpful it was to so many patients. And it's been approved and available for our use in the United States as of May 17th. And I've been prescribing it quite a bit to my patients, and it's been, for some patients, it can be a game changer. Obviously, it doesn't help everyone, but a few things to note. This is a single injection that patients will give themselves sub-Q monthly. So rather than being an oral medication they have to remember to take every single day, it's just one shot once a month. And because it is a targeted treatment, a monoclonal antibody, the side effects are actually quite minimal too. The main side effects with all of these CGRP monoclonal antibodies that were shown were some injection site pain and about a 3% risk of constipation. So it's pretty minimal. And about 50% of patients who were given this treatment saw about a 50% reduction in their migraine attacks. About a third saw about a 75% reduction, and a minority of patients saw even 100%. So obviously this is not going to help everyone, but there will be some patients for whom this is going to be a game changer. So it's very, very exciting. Erenumab is just the first to be approved. There are 3 others that are being studied, 2 of which they've already submitted their data to the FDA, and we're waiting for their approval. The final one should be submitting it shortly as well, but they've been studied in episodic and chronic migraine. A few of these have been studied in cluster headache, which is a debilitating headache condition for which we have very limited treatments, and all these studies have been positive. So I think this is going to change the way we look at and treat migraine going forward. And a few additional slides on medication overuse in migraine. So most of our patients who have migraine are unfortunately overusing acute medications. Up until about 2013, we were unable to diagnose a patient with chronic migraine if they also met criteria for medication overuse headache. That changed in 2013 and has remained consistent with the latest version of the ICHD published in January of this year. So for medication overuse headache, it's a chronic daily headache picture in someone who already has a diagnosis of migraine. And over a 3-month time frame, their headache has worsened, and they've been taking excessive amounts of acute analgesics. And we talked about chronic migraine before. So those 2 diagnoses can coexist in a patient, which is, I think, important because it expands our treatment options. We're still trying to better understand how to best manage medication overuse headache. We actually have a trial going on in the US looking at that very thing. Should we just reduce their medication? Should we just put them on a preventive treatment? What should we do? But I think for many headache specialists, we believe that you need to do both. You need to try and stop the medication that's being overused and start the patient on a preventive treatment to treat their underlying headache condition. Most of the time, just doing one or the other is not sufficient. So a few clinical pearls that I hope you can take back to your clinics. So when you see a patient with headache, they will often come to you and only talk about their worst headache days. It's not uncommon for me to see a patient in clinic who says, doctor, I have a really bad headache. It happens 4 times a month. I'm bedbound. I can't do anything. You have to help me. Well, 4 times a month, that sounds like episodic migraine, but then we keep talking. And I ask them, well, what about the other days in the month? Are you headache free? You have no pain? It's just those 4 days? And they say, well, actually, no, I have my daily headache. It's not so bad, right? So all of a sudden now we've gone from episodic migraine to probably chronic migraine, maybe even medication overuse. The picture has become more complicated, and I have a better idea of what I need to do. Patients don't often always tell you everything they're taking. Sometimes they just tell you about the prescription medicines. So I ask them, tell me everything. Tell me all your supplements. Tell me things you buy over the counter, because all of that can play a role in their migraine frequency as well. And then finally, I think it's really important to set realistic expectations with our patients too. Remind them that it can take time for these preventive treatments to work. Even with these new CGRP monoclonal antibodies, we don't have a titration period. We start them on the dose that they need to stay on. However, for some patients, it can take a few months to see a difference. So in conclusion, migraine is a very prevalent disease. Over 1 billion people in the world are affected by it. It's disabling, it's costly, and there's a huge gap in that about 40% of patients are eligible for treatment but are not on it. When you choose a preventive treatment, think about your patient's other medical issues and see if you can pick a medication that might work for more than one problem. And these new treatment options that are being added to our migraine toolbox are just adding our options and hopefully bring your patients closer to some hope. And I just want to conclude by letting you all know that in March, my colleague, Dr. Amal Starling, and I will be co-directing the Mayo Clinic Headache Symposium, which is a weekend-long headache course. If you have been interested by any of the things I've talked about, please come and join us. We'd love to have you. We'll have some skill workshops and talk about these topics in depth. That's all. Muchas gracias.